Okay, guys, well, I think we'll start. My name is Dr. Jeff Gerber. I'm a family doctor from Denver, Colorado, and this is my second year as a member of Physician in Ancestral Health. And personally, it's just an honor to be part of this group. I think that we're really redefining the delivery of healthcare, so kudos, and we're small and growing. So I'd like to talk to you today about diabetes, heart disease, and navigating through the muddy waters of cardiovascular risk assessment. So I want to begin by introducing you to a couple of people. And in the middle is yours truly. And on the right of the screen is my engineering problem-solving friend, Ivor Cummings, who you might know. And he convinced us last summer to fly out to Chicago to visit this spry young physician, Dr. Joseph Kraft, who was just turning 95 in this photo. And you'd ask, well, why do we want to visit a physician such as Dr. Kraft? Well, Dr. Kraft is a pathologist, and he spent a career studying insulin metabolism, looking for root cause, chronic disease, and also cardiovascular disease. And through his career, he noted that there was a strong connection between diabetes and heart disease, so much so that he said that those with cardiovascular disease not identified with diabetes are simply undiagnosed. And I'd like to explain to you why he said that. And so a little more about Dr. Kraft. So again, he's a pathologist. He was actually the chief of the Department of Pathology and Nuclear Medicine at St. Joseph Hospital in Chicago for over 35 years. And during that career, he created the 5-hour insulin assay based on the radioimmunoassay. And he actually did over 16,000 insulin assays on patients because of his great interest. He also had done over 3,000 autopsies, so he's actually looking at pathology. He collaborated with many other physicians and researchers looking for root cause. And after he retired, he wrote a book. And the book is called Diabetes Epidemic in You. And it's a good read. It actually is more like an article you would find in a medical review journal. But I just actually found it fascinating, and the Eads have just arrived. Welcome. And it's a great read, and he really summarized his career, including the fact that he was written up in peer-reviewed journals throughout the career as well. So one of the things that Dr. Kraft wanted to set out to do was to demonstrate that standard methods of diagnosing prediabetes and diabetes were inferior. And by the standard methods, we're talking about measurements of blood glucose, either fasting or during a dynamic oral glucose tolerance test with a challenge, and even a hemoglobin A1C. And so the standard methods that he used, and fortunate or not, we use them today, include measuring fasting blood glucose, such as 100 milligrams per deciliter. Also doing the 2-hour glucose challenge, either giving 75 grams or 100 grams of glucose or dextrose. In Dr. Kraft's work, he actually gave 100 grams of dextrose, and we know that 75 is more standard, but you can kind of correlate the two. And if the 2-hour glucose is over 140, of course, that would be abnormal. Now, what Dr. Kraft also showed is that, unfortunately, the screening tool, the gatekeeper, the fasting blood sugar, is just absolutely terrible because people don't move on to other testing, such as the glucose tolerance test. You can actually pick up a couple more people. But he indeed showed that it was inferior to measure just blood glucose. So talking about Dr. Kraft's 5-hour insulin assay. So his work really started in the late 60s and 70s, and radioisotope, radioimmunoassay studies and the technology were just being developed in the 50s. And he basically embraced that technology, and we were beginning to understand that non-insulin dependent diabetes, that they called it then, now type 2 diabetes, was a disease of insulin excess, but nobody had really quantitated the insulin levels, and that's what he set out to do with the 5-hour insulin assay. So he was now trying to create this gold standard test to define hyperinsulinemia. And so in his book, out of the 16,000, he ended up with over 14,000 people that he reports in the book. And it's similar to a glucose challenge in that you give glucose in the beginning of the test. In his case, it was 100 grams of dextrose. And you monitored both glucose and insulin over a 5-hour period of time. Again, he did this in over 14,000 people in his book that he reported. That's just astounding. And when he looked at the data, he found that it clustered into 5 distinct patterns. So there's pattern 1 that he called normal. There's pattern 5 that he called low insulin. And then there were 3 patterns, pattern 2, 3, and 4, that he called hyperinsulinemia, or his term, diabetes in situ. And really what he was trying to create a gold standard that would diagnose both diabetes, prediabetes, and even redefining diabetes at its earliest stage. So we'll take a look at some of the patterns, and I have to thank Ivor Cummins for providing me with these awesome looking graphics. So this is the pattern 1, that is eubinsulinemia, or a normal insulin pattern, where you see that the fasting insulin level is low, normal, and the insulin in micro international units per ml doesn't go much up above 60. And then in this slide, we can see the normal insulin pattern in the blue, and superimposed are these other 3 patterns of hyperinsulinemia. And so pattern 2 and 3 in the yellow and the orange have a normal to low insulin fasting. Pattern 2 peaks early, and pattern 3 peaks late. And then we have pattern 4, which is different in that the fasting insulin is high, and I believe that's somewhere above 50 microunits, and then it peaks way high. And so you can clearly see that he's measuring a condition of insulin excess and beta cell overproduction of insulin. And then we have what I call the pesky pattern 5. And so this is the low insulin response. And so you might think about, well, what patients would this apply to? And the most obvious are type 1 diabetics. They're not producing insulin. I think another group is a type 2 diabetic who has burnout of beta cell function, and they're not producing insulin. But here's where it gets pesky. And Dr. Kraft actually described this as patients on a low-carb diet have a low insulin response, and also patients in a starvation state have a low insulin response. And he actually, in 1975, he has a paper that showed people on a low-carb diet that expressed this pattern. If they went off their low-carb diet and went on a high-carb diet, or they preloaded prior to doing a glucose tolerance test, you could see their insulin start to spike. Now, he didn't use the terminology, but a lot of us have used the word today that this is a representation of what we call physiologic insulin resistance. And it took me some time to understand this, but we might think of it as a normal physiologic response to a low-carb diet. And I find this fascinating because I've been doing glucose tolerance tests for over 15 years. And the question is, should people on a low-carb diet get this Kraft insulin assay? And it depends if your practitioner knows what they're doing with the test. So one of the things that Dr. Kraft said is that hyperinsulinemia occurs before hyperglycemia. So how can we demonstrate that? Well, we have to thank my friend and colleague, Catherine Crofts, who's actually a PhD candidate from Auckland, who is doing her thesis on Dr. Kraft's work. And this is actually unpublished data that will hopefully be published in the next couple weeks, but she allowed me to use it. And basically what it shows is a subset of patients who had those patterns of hyperinsulinemia. It's actually 2, 3, and 4, but she actually broke it down into pattern 2A and 2B. And in each case, we can see that the patients had an abnormal insulin response, and yet their glucose measurement was normal by standard methods, meaning their fasting blood sugar and their 2-hour. So indeed, you can see that hyperinsulinemia occurs before hyperglycemia. I still wasn't convinced, because I've been doing glucose tolerance tests for over 15 years. Now, I think about it a little bit differently, but I thought there's some utility to it, and I really wanted to compare glucose to insulin. And so what I did was recompiled Kraft's data. And so this is the slide that is going to make your eyes glaze over, because this is a confusion matrix. And I always got this wrong on the medical board when they asked about this, but I think I'm getting better at it. So the confusion matrix, to try to explain it, is comparing one method to another method. And in this case, on the top, we're comparing the Kraft method of measuring hyperinsulinemia, which is the gold standard that tells you if you have disease or no disease, to the standard method of hyperglycemia, or measuring glucose. So if you look on the right of the slide, the positive and negative predictive value will tell the individual who gets the test what their likelihood of having the disease is based on having a positive or negative response. And we're talking about measuring prediabetes and diabetes using glucose, okay? And then if you look at the bottom, the sensitivity and the specificity will tell the researcher or the clinician how accurate their method is, in this case, measuring hyperglycemia. And what you can see is on the right side, there's a high positive predictive value of 97% and a specificity on the bottom of 92%. And that tells you that if you do standard testing and you get a high blood sugar, you're good. You know that the patient's got a problem. In fact, you don't even have to do an insulin assay. But on the flip side, the problem is when you get a normal glucose pattern. And you can look at that negative predictive value of 28% and sensitivity of 52% to tell you that you're not okay. And to further explain that, on the next slides, we can see that you get your standard test and you come back, you're euglycemic, your blood sugar is normal. Well, based on negative predictive value, you can only be 28% certain that you're normal. On the flip side, you're 72% uncertain. So it's not very good. And I just said if you have hyperglycemia, you're good. But based on sensitivity, you're still missing 48% of the people that have a problem. And so I think this really demonstrates that a normal standard test of glucose isn't reassuring at all. So the next question, could the Kraft test predict population risk? And the test wasn't designed to really do that. It was really designed to just create a gold standard method that was much better than standard methods. But you can apply the Kraft method to other populations. And so last year there was a National Health Survey study that you may have seen, and it estimated that up to 52% of the population are pre-diabetic and diabetic. Now that's astounding, and it received a lot of criticism. But yeah, that's probably right on track. Now, they did one step better than just looking at NHANES data. They took the cohort from 2011 and 2012 that was a representation of the US population. It was almost 3,000 people. And they actually did really good standard testing. They did fasting blood sugars. They did oral glucose tolerance test. And I think that's right on that figure. But if you now think about having done an insulin assay, a Kraft test on all these people, you'd realize how many you're missing. It's astounding. So, to shift gears, I'd like to talk about cardiovascular risk and ask the question first, is there a diabetes paradox? So some people say that despite us seeing more diabetes and obesity over the decades, that there's actually less heart disease. And so I'd like to just think about that for a moment. What I believe is true is since 1995, we've actually seen mortality and morbidity from heart disease go down. And that really represents modern medicine, the cardiologists actually doing a great job treating the complications of sick people. EMTs. And yes, EMTs, absolutely. Yeah, so we're really gotten much better at treating complications. Smoking cessation may have a lot to do with this as well. But that doesn't necessarily mean that the insulin incidence and prevalence of the condition has been dropping. And that's really the whole point of this presentation. And so everyone admits that getting at incidence and prevalence is a difficult metric to find. And so the question is, how do you look at that? And so I think one way is to look at subclinical disease. And one way to do that is through cardiovascular imaging, and even at autopsy, where you can look at progression. And when you start to look at this type of evidence, you can see that with more diabetes and more obesity, there's more heart disease. So there is no diabetes paradox, in my humble opinion. So what did Kraft have to say about cardiovascular disease? So he recognized that it was a metabolic disease, and the pathway was through that of hyperinsulinemia. And he noted that all his patients that had cardiovascular disease failed his insulin assay. And he suspected that if every cardiac patient had had his test, they would have failed as well. He also suspected that people that were absolutely normal on his Kraft assay wouldn't have heart disease. And the point is, if you're missing and not thinking about diabetes and prediabetes, you're missing heart disease risk. So then we have Dr. Jerry Raven, who comes along in 1988, and he makes the headlines for talking about Syndrome X. We now call it the metabolic syndrome. And he too recognized that coronary heart disease was a metabolic disease. And the metabolic component he called insulin resistance. Now, insulin resistance and hyperinsulinemia are in the same pathways. Maybe the insulin resistance is downstream, but the components of that included glucose intolerance, hyperinsulinemia, atherogenic dyslipidemia, where we're not looking at the concentration of cholesterol, but we're actually looking at the quality of cholesterol, the triglyceride to HDL ratios, the particle size, and so forth, and then hypertension. And when I had first learned about the metabolic syndrome, to me, this made a lot of sense. We finally had a solid mechanism to explain cardiovascular disease, and I thought this would catch on. But unfortunately, despite most healthcare professionals being familiar with this, it didn't gain much traction. And you wonder why. Well, there wasn't really any medication to address this. That was the big problem.
No, metformin addresses it to a degree.
Yeah, there are other medicines now, GLP-1 analogs, but in the traditional sense, it was really a lifestyle illness. And it just wasn't backed or funded by big pharma, unfortunately.
Metformin's cheap, so.
Yeah, metformin's cheap. And
It was even after this paper.
yeah, but yeah, you're not going to make any money off of metformin at that point. You know, it was generic.
No, metformin came out in the mid-90s.
Uh-huh.
So, I mean, this was done.
Well, glucophage. Yeah, glucophage.
But berberine was already studied by this point, which is equivalent to metformin. But I'm sorry to interrupt.
Yeah, but that's all nonsense. You know that it really was a lifestyle illness that they were trying to address with this. And the other point is it's interesting that Kraft and Raven, although they were on the same pathway, never really collaborated. So after the time of Kraft and Raven, you look in the medical literature, and it's really well established that there's this strong link, if not a causal link, between diabetes and heart disease. But when it comes to clinical medicine, not so fast. So on the one side, we have diabetics that don't know that they have a heart problem. And the other side, we have heart patients that don't know that they're diabetic. And so you ask, why is there this big disconnect? Well, I'd like to welcome you to the Framingham distraction. Yes, that's Framingham, Massachusetts. So Framingham is where the original epidemiology studies occurred starting in the 1940s, looking at cardiovascular risk factors such as lipids, smoking, hypertension, diabetes. And since the time of Framingham, they've come up with different risk assessment tools. They've now come up with risk calculators, and it's honestly all based on the original Framingham work. And the central theme is to lower cholesterol, total cholesterol, LDL cholesterol, and that's it. And therein lies the problem. So diabetes risk is there, but it's just buried. So what's important about cholesterol anyway? So that's a good question. So the medical doctrine tells us that high cholesterol is a bad thing and it requires remedy. Well, okay, well, what's the mechanism? Well, that's another good question. So I'm not sure. Again, I've been doctoring for over 25 years, and they talk about some type of concentration gradient in the arterial blood wall where the cholesterol gets in. You know, in recent years, they're talking about inflammation. I like that. But the mechanism really remains elusive. And so what about experiments to prove this hypothesis? And we can take, for instance, in 2008, the Jupiter trial, which tried to tell us that we should put statins in the water. And the best that they could come up with, if you believe it, is that the absolute risk reduction for primary prevention of a non-fatal MI was only about 1%. So it's not very impressive. And so we can poke at this and debunk this lipid hypothesis and still call it a hypothesis that's never been demonstrated. And we can look at some associative studies and understand that this doesn't prove anything but raise good questions. And so in 2009, there was the Get With the Guidelines study where they looked at a group of patients that were hospitalized with acute cardiovascular events. And 75% of them were actually at cholesterol goal. And so you ask, well, if they're at cholesterol goal, why were they in the hospital having a cardiac event? Debunk number one. So the second study last year towards a paradigm shift in cholesterol treatment showed that elderly people live longer with higher cholesterol. So these are just thought-provoking studies. So then when we look at the mechanism of hyperinsulinemia, again, it's solid, okay? And the mechanism is that of oxidative stress and inflammation leading to advanced glycation end products that is ultimately inflammatory to the endothelial lining is what we're trying to represent here of the arteries. And it's just a total inflammatory pathway. And then when you look at the experiments, again, the more diabetes, the more heart disease, the more inflammation. In fact, when you actually look at the studies that try to implicate cholesterol, if you dig deep, you can see that it was insulin as the problem all along. It's absolutely fascinating. So, if you have to pick, is it going to be the muddy Framingham risk assessment or looking at diabetes as a risk factor all by itself? And so it's important to look at the middle risk population. And so everyone agrees if you have somebody walking through the door who's a smoker, a diabetic, overweight, they're a walking time bomb. So you don't really need to do risk assessment, but we're talking about middle risk population. So people that might be a little bit overweight, they're not even smoking, they have no idea if they're diabetic. So Framingham might predict a 2 to 3-fold risk compared to baseline. But when you look at their risk in terms of diabetes and prediabetes, the risk might be 8-fold. And then again, Kraft says you're missing all the diabetics anyway. So if you're a gambling person, you go with the diabetes risk assessment as an independent marker of risk. Bottom line, it's the insulin, stupid. And I'm talking about the good doctor there. So you want to focus on insulin excess, insulin resistance, and inflammation, and to recognize that atherosclerosis is a symptom of diabetes. Many people are at risk, and we're not recognizing them. And again, traditionally, it's not pharmacology, it's really lifestyle that we want to address with our patients. And so the question, what is the diet and lifestyle modification that we're looking for to prevent those arteries from getting clogged? So I think this image is representative of junk food. And I think to just tell people to stop eating junk isn't enough. We really need to qualify it. And so what would be the recommendations? And for me, I think about what drives insulin metabolism. So it's carbohydrates first, protein, and then fats, natural fats that don't drive insulin that much. And so these are the recommendations that we provide to our patients. We tell them low carb is best, moderate protein, high in fat. We're cutting out sugars, grains. Also, the industrial vegetable oils tend to be very atherogenic as well. And we're eliminating processed foods. If we're doing number 1 and number 2, well, our patients are going to eat less. But I think it's important that they know that the goal is to get them to eat less, okay? Movement and activity, not because that is going to help you lose weight per se, but there's so many other benefits to activity. And that's kudos to Daryl, who's in the audience today. And of course, smoking cessation, proper sleep happiness. So the clinical assessment, it's important to think about insulin and hyperinsulinemia early on to recognize that our screening tools, the fasting blood sugar, hemoglobin A1C may not be that good. However, we're getting a little bit better, looking at A1C. For instance, in our office, we're trying to get to see hemoglobin A1Cs under 5 as normal, whereas the American College of Clinical Endocrinologists, ACE, will tell us that 5.7 is prediabetes. So those aren't bad. To get clinicians to think about even doing oral glucose tolerance tests, because they can actually pick up more people. And then to modify the test, so we actually do a 1-hour glucose, and the cutoff is 155, and we have a link to the study that showed us that that's not a bad metric to look at. And then, of course, to measure insulin. Now, Kraft noted that, unfortunately, he didn't find much value in fasting insulin, although we do measure it, and so perhaps 10 microunits might be a cutoff, or at least when you're doing your fasting insulin to think about some of the other parameters, inflammatory markers, lipid ratios, those kinds of things. So what Catherine Croft did in her thesis is to say that practically speaking, this 5-hour insulin assay is very hard to do. And to simplify it, she's come up with a method where you just simply measure a 2-hour insulin after the glucose challenge. And the cutoff for her is 30 microunits. And we've actually started to do that. And it's just another metric that can be really helpful. And then again, you could do inflammatory markers, lipid ratios, and just think about this early on. Okay. So we're almost done. I actually just wanted to talk now about cardiovascular imaging. And so talk about trumping Framingham risk assessment. We're actually looking at clinical disease. We can look in the arteries and see the endpoint. And so we have several tools. The image here is, of course, of a heart catheterization that is rather invasive when you're having a heart attack and at risk of dropping dead. So, you know, it's an invasive test. And so the idea is we want a screening tool that's going to be relatively inexpensive and non-invasive. And so I think that the coronary artery calcium score really fits the bill. And so I'm going to show you here a little bit about the coronary artery calcium score. And so we have two patients. And so the technology is that we have this beating heart, rapidly beating with these tiny coronary arteries. So we need advanced technology. So we have the high-speed CT machine that can image this. And the idea is that normal arteries don't have plaque and they don't have calcium. And so as plaque develops, at first is soft plaque, which you can't necessarily see on the calcium score, but eventually calcium builds, and then you can measure the calcium through time. And so this individual on the right looks like a rather older person. You can tell by the muscle mass. And you can see this is a one-shot image of the left anterior descending coronary artery. So we actually see 64 slices of the image, and Dr. Eads knows quite a bit about this. We've talked about it over the years. And this would be a very high calcium score, and I'm suspecting this would be in the thousands in terms of units. And then on the left, we have another individual who is me. So that's Dr. Gerber last year. The male is 54 years of age then, has been on a whole foods diet for over 15 years. And my left anterior descending artery has no calcium, and that's the trend throughout the entire 64 slices. And so I have a perfect calcium score of 0, lucky me. And my 10-year risk of having a cardiovascular event is less than 1%. That's awesome. Thank you. Knock wood, I could drop dead from something else, but let's hope that luck will be with me. And so what you can do is stratify the risk based on the calcium score. And you can see as you have more calcium, your risk goes up. And you can stratify it based on age as well. What else is really important is the progression of calcium. And so if your calcium score progresses by greater than 15% per year, you're almost doomed. And so you can see in this individual where the calcium score is over 1,000, at 2.5 years out, their mortality drops to almost 50%. So that's kind of scary. But on the flip side, if you don't have progression of calcium, on the left, your survival doesn't change. So it might be scary if you get the test and have a calcium, but if you follow it over time and there's no progression, you're good. And so I think that the cardiovascular imaging is just a really powerful tool that we should think about it.
So how many rads do you get with the CT?
Yeah.
I'm sorry?
How many rads?
Radiation exposure.
Yeah, so we've referred to it as the mammogram of the heart. So it's gotten a lot better. And so you have to consider the invasiveness of it.
Risk of leukemia and other cancers associated with
Yeah.
imaging.
Well, it's interesting. Some suggest that women would be better off getting a calcium score rather than a mammogram.
Just forget mammograms altogether.
Thank you, Deborah.
Eric Topol said if it were a drug, the FDA would never have approved mammograms. I think that's brilliant. But anyway.
Brilliant, brilliant.
So practically speaking, though, people aren't going to be getting annual calcium scores. They're expensive, various things. So most of my patients, they'll come in and they'll have some sort of a score, and they're not necessarily very healthy, and or they get it repeated. They end up in a cardiologist's office, and then they send them because they love that, and then so their score goes up.
Yeah.
And the question is, why did it go up? Because their diet has now stabilized things, calcified it, made it better, because we know they had soft plaque before, maybe from a CIMT or something like that, or has it really gotten worse. And that's the problem I have with this particular test, because
Agreed.
interpreting it,
No,
5, 10 years after the first one, you don't know what to do with the information.
Your plaque can be stabilizing and your score goes up when you
Yeah.
stabilize plaque.
Right, so there's debate as to what is stable plaque. And debate goes on, obviously. But again, this data that I presented is based on tens of thousands of patients. And so it's absolutely solid. If you stabilize your plaque, your risk.
The difference between an individual's data and the individual circumstances and a public health or
Sure, absolutely.
risk assessment.
And the other point is that this shouldn't be a test.
Lowering LDL helps too, right?
Right, so this isn't, the cardiologist invented it. This isn't a test for the cardiologist. This is a test for primary care physicians and who understand primary prevention, okay? Steve Nissen, who is in charge of the Cleveland Clinic, doesn't know a thing about primary prevention. Excuse me, Dr. Nissen, okay? So this is a whole different ballgame when we're dealing with it. So anyway, just to finish up, so I hope that the muddy waters are clearing when it comes to cardiovascular risk assessment. And so when you or your doctor is grabbing for that Framingham risk calculator, you ought to be thinking about insulin and hyperinsulinemia, because what's most important is to recognize that diabetes is a vascular disease. Thanks. Rick has a burning.
Question for you.
Yeah.
With the popularity and the ease of getting an A1C, what is the positive predictive value of an abnormal A1C?
A1C. I don't know the answer to it, but we check A1Cs, and if it's over 5, we're suspicious, and we want to do further testing.
You use 5 as your cutoff to do more testing.
Yeah.
What do you Chris Mercer has, I guess you just do more testing. I mean, his point is if you're really healthy, you probably turn over red blood cells a little more slowly than the regular population. I mean, I have really low insulin, but I have kind of high fasting blood sugar and high A1C, 5.6, something like that. But it probably, you would have me do a glucose tolerance test.
Deborah, that's a great question. So, I live at altitude, and you got to consider the life of the red blood cell, how much red blood cell, and we have similar populations. All the metrics look good, but the A1C is 5.4. We even do the glucose tolerance test and insulin, and everything looks great, and the A1C is 5.4. So you have to understand that a hemoglobin A1C is just an averaging technology. So it's not all telling.
But it does help the insurance company pay maybe for the next time.
Yep.
Right on.
So
Good for the insurance company.
I have a lot of patients who are sent to me by their doctor because they're told they have a high cholesterol. They just look at total cholesterol and want to put them on statins. And so they send them to me for another opinion. In that case, would you just say, let's do a diabetes workup and not even do an NMR, a specialized lipid panel on you?
Yeah, I would. Well, first you got to jump and do the insulin evaluation, and
But the NMR panel, of course, is a good one. What do you think of that insulin resistance score, that HOMA insulin resistance score that you get on the NMR?
I think it's weighted on the total cholesterol. I think it's.
No, it's not.
I think
rated
it.
on particle number, triglyceride particle number.
Yeah, all that
HDL
is,
particle
but.
number, it's-
But it comes back with a high insulin resistance score, and I disagree with it because I see other factors such as the particles and the ratios and looking at other markers. So you can look at it, but I don't find that insulin resistance score so good. But I do advanced testing just to reassure patients that have high cholesterol that the quality is favorable.
But you jump to a glucose tolerance test soon. I mean, this is instructive.
Yeah,
about
so-
that. I don't do that.
Insulin evaluation is looking at inflammation. So I do the whole inflammation workup is another way to think about it.
That 5-hour insulin test, do you think that's subject to the diet in that last week? If they ate really well for a week, is that going to influence that
Yeah.
test?
So that's the physiologic insulin resistance part. And so Dr. Kraft even said that you have to put them on at least 150 grams of carbs a day for even 7 days to 2 weeks, which, how can you make people do that? I mean, that's just terrible. And so,
Why is that terrible? To take 100 grams of carbs for a week to make your test more
well, if you have patients that are on a ketogenic diet, and to tell them to do that is, but
resistance is physiological
but-
insulin resistance.
yeah,
Much
but-
the waters.
right. But on the flip side, you can just not carbohydrate load them and then just do the insulin assay. And if they get a low insulin response and you know they've been ketogenic, well, you say you're having a physiologic response. So, you know, again, you have to think about doing it on particular patients. Meridian Lab, actually, your patients can do it on their own if they want, which is really confusing. I think we're done.
We got to wrap up.
Yeah. Thanks, guys. Okay.